Hello, everyone. We are Amicus Brain. Amicus Brain Innovations is a digital health technology startup focused on bringing the power of artificial intelligence technology to transform care management for people living with neurodegenerative disorders. We are about making technology solutions available to everyone to reduce caregiver stressors, increase self-efficacy, and enable people living with dementia to remain at home longer. So our AI advisor apps make dementia caregiving easier, taking out the complexity and saving precious time over the progression of the disease. November is National Family Caregivers Month, and today we bring you our knowledge sharing series that are expert-led dialogues, providing a venue for knowledge exchange, caregiving tips, and solutions for family caregivers. We are delighted to begin this series with a conversation with Dr. Rajam Iyer, who will share her insights about palliative care to improve quality of life for both the patient and the family caregiver. The event will be facilitated by Geeta Iyer. We will then conclude with Q&A from all of you. As you listen, please use the chat to share your experiences, make your comments, and raise questions. So now, over to Geeta, who will begin with introductions. Thank you.
Thank you, Shri. And I want to welcome Dr. Rajam, or Rajam, as she would prefer to be called, to this conversation, very important conversation, and that has become very close to my heart. Before I ask her to introduce herself, I want to say a few words about how I got to know her. It was quite serendipitous, and the context is very relevant. Some of you know that I moved from the US 3.5 years ago. I moved to Mumbai to take care of my father, who was in his 90s and he had Alzheimer's. So he passed away in 2020, and the last month and a half were very painful for all of us. For him, he was experiencing extreme physical pain and possibly emotional, but he couldn't communicate. He had lost the ability to communicate. And we were trying to give him all the medical help. He had an urinary infection. And so all the possible medical help to treat that, but our options were very limited. So what I needed was to keep him comfortable. So in this context, I knew that if I were in the US, he would be in hospice. So desperately in my support group for dementia caregivers, I sent a post saying, is there an equivalent of hospice in India? And that's how I got the contact for Dr. Rajam. I reached out to her, and she was very prompt in responding. And the first call was very familiar, there was empathy that came through. And she wanted to help. And we set up a call immediately on Zoom for the following day or so. And what was striking was she insisted that my sister in the US participate. She realized that I was feeling alone in many of the decisions, and she wanted me to have as much support from family and as possible. And then as it turned out, my father passed away a few hours before the call was to happen. Another remarkable thing, 2 days later, I was on my way to scatter my dad's ashes in the sea, and I get a call from Rajam just to see how I was doing. She was checking up on me, and that was completely unexpected, and I felt it was going above and beyond because she did not know me at all. I had only spoken to her once, but that kind of care and empathy, I will not forget. So I think it kind of underscores the essence of palliative care, what she's doing. So now I want to say thank you for all that, and I want to ask you to introduce yourself and also talk about how and why you're doing, why you're in this profession, palliative care. You moved from being pulmonology to palliative care. So
sure. Thanks,
welcome.
Geeta, Shri, and Chitra for all the wonderful work you're doing. And thank you for having me here. It's as much my interest to be here as it is all of yours. So I can see that our passion can get channelized to something better and for a better future. So I am a trained pulmonologist and only lived in Bombay. I did finish my MRCP from England in the year 2007 and came right back because that's when my parents were getting 80 plus. And I thought it's best I look after them and not look after others in the world. So I stayed, I came back and started working here. And in 2015, my father had a stroke and he was 88 when he had the stroke. And that's when I realized, when I spoke to my friends and colleagues, that at 88, the neurologist or the neurosurgeon couldn't do much for Appa. And they were very clear that at this age, we can't reverse his situation. So I spoke to my mom at that situation, at that time, and also my sister who lives away, and said that if it is irreversible, I don't see a sense in prolonging his poor quality life. Let's keep him comfortable and offer him the dignity and respect he deserves. And all that dignity and respect that he has brought us up with, it is time for us to give it back to him. They all agreed. And we decided to keep him at home in his own bed, in his own room. We gathered around him. It was an excruciating 3 weeks of our lives. But on hindsight, I think it was the best that he would have asked for in the given situation. We didn't do a single blood test. We didn't do a single monitoring. We just kept him clean. And like all of you know how South Indian Brahmins wear, we made him wear his 3 vibhuti marks, his chandanam, his kungumam, and it was just like he was sleeping in the room. And we waited. We waited for 3 weeks, and he waited for an Ekadashi day to pass away 3 weeks later. And that's when I realized, Geeta, that as a doctor, I know how painful those 3 weeks were. I was born his daughter. I was not born a doctor. And I know, for me, having been a doctor for 25 years, I needed a colleague or a friend of mine to come and tell me, Rajam, you're not doing anything wrong. Talk to my mother, talk to my sister, send us food, stay with us in the nights. I needed so much support. And that's when it hit me that if I needed so much support, how do the non-medicos in this country survive such a disaster? Because all they can think of is rush the patient to casualty. And then the patient is treated like it is in a conveyor belt, into ICU, onto the ventilator. Nobody thinks of what the patient wants. And this is when I read a beautiful editorial by the father of Indian palliative care, Dr. M.R. Rajgopal, who is the chairman of Pallium India, which is an NGO in Trivandrum. And his topic of the editorial was "Don't torture the dying." I was so taken up by his writing. I wrote him an email, and in the next week, I was in Trivandrum with my mother in tow in September 2016 for a 10-day training to find out what is palliative care. And since then, I have done my fellowship in palliative care from Calicut and my diploma in palliative health medicine from the University of Cardiff. So my life has completely changed gears, and I thank my dad that even in his passing, he showed me the direction for future, and it really has given me the drive and passion in life to attempt to decrease suffering in this world.
That's I'm really touched by many of the things that you said. Particularly, I was born a daughter and not a doctor, and many other things. So I want to talk about, right at the beginning, what is palliative care, right? Because I've seen that a lot of people, when they think about palliative care, they think about end of life. And in one of my conversations with you, you said we die only once, but we live every day. So can you talk about what palliative care really is, and how it focuses on quality of life and every day, not just end of life?
Yeah. So when I went to Trivandrum for the training, it really opened the world for me. And by definition, the latest definition of palliative care by WHO is attempt to alleviate health-related suffering. So it need not be physical only. It is emotional, psychological, financial, spiritual, and also psychosocial. Plus, it aims not just at the patient, but also the caregivers, because the entire family unit suffers with the patient. And the beauty about this is that it is not related to the earlier definition said chronic illnesses. But come the pandemic, it has completely changed that definition also. So anybody who is suffering any health related illness. It could be just the logistics of getting a patient to get a CT scan done, getting the bloods done, getting multiple visits for chemotherapy. There's so much thing that entails, especially in India. Not everybody has a car. The hospitals don't send ambulance. It is not, everything is not free like Europe. You know, you have to pay for everything. Everybody is not able to afford. So the definition of palliative care is health related suffering. It need not even be for terminal illnesses. Yes, the focus is on chronic terminal illness where you know there is no cure. In such situations, you really need to focus on how you can make the person's quality of life important and not focus on the quantity, because we know there are certain many conditions in the world which are incurable. Those patients and human beings also need and deserve to live. So palliative care for them is a birthright. It is something that everybody needs to have access to. Everybody needs to be aware of their rights to be comfortable, even if not cured. So the whole concept of health care, you know, that care word is completely forgotten, because during our training, we are focusing on cure and save. It's drilled into our medical training that you have to find a cure, keep doing. And that's why palliative care very often is misunderstood as giving up. How can you not be focusing on care? How can you not do ICU? How can you not do a ventilator? So we as doctors have forgotten the art of prognostication and forgotten the art of foreseeing and foretelling. Because Geeta, I know the natural history of, because I'm a pulmonologist, of a smoking related lung disease. I know there is no cure. But till I got into palliative care, I never told a patient, I'm only treating your symptoms. I'm not curing the lung, because the lung is anatomically destroyed. I can't get your normal lungs back. So the patient is under the impression that this doctor is treating me. I am telling him, take the inhalers, you will feel better, but the lungs are going to deteriorate. Suddenly, when the patient is critical, that's when I decide to say, sorry, I'm not able to do anything. Patient is not prepared. Relatives are not prepared. They say, doctor, do everything. So in a private sector, like in India, where more than 80% of people go to private hospitals for healthcare, it is a boon, because it is a money-making also, because corporate hospitals survive on multiple admissions, prolonged ICU stay. So somewhere in all this, the ethos of medical health care in this country is lost. We will not find compassionate, empathetic doctors because we are not trained to be like that. And it's very, very sad that I never got trained, and I realized the suffering only when I went through it. And you know, that's when I realized, when somebody describes the situation at home for me, when one parent is not well, the other parent is elderly, you are the only person doing everything. It really, I know what that person is going through. So palliative care is addressed at health related suffering. The earlier you integrate it, the better it is. The other myth people have, because historically it was started for cancer patients. Very often when you tell palliative care to patients without cancer, they say, I have not got cancer, or I am not ready to die yet. So it is not related to cancer, and it is really not related to end of life. End of life is a part of palliative care, and palliative care goes beyond end of life, because we look after caregivers going through bereavement. And that was my call to you, was my bereavement call, to check how you're doing, because you obviously had shifted lock, stock, barrel. That had moved me, that you've come, or changed your course of life to come to India to look after your elderly parent, and the void that loss leaves behind, it cannot be filled by anybody. The least I could do was make that call to check out if you were okay. So that's the spectrum of palliative care.
No, that is, I mean, that really touches me, the whole way it works, and the empathy, and it's rooted in caring, so that is something that has kind of changed even in India, because there was a time when you had family doctors. So I'm lucky to have doctors that are like family, but still they are treating the disease. They're treating the disease, but beyond that, I think there could be more awareness or pointing to something like palliative care. So can you talk a little bit about the training? Because I think there needs to be awareness on both the side of the on the doctor's side and the patient side. So on the medical side, I think, is there enough training available? You somehow, because of the experience that you went through, you saw this, you read this article, and then you got trained in this. Is it integrated enough in medical colleges, in the curriculum, that it becomes part of the regular thinking? Is that, or it could be more? And also on the patient side.
Sure. So the other thing, so I think the MRCP training kind of geared me to it, because the MRCP training has sessions on, communication. It has sessions on how to talk to patients, etc. Till September 2019, the medical curriculum in India had no training or no hours dedicated to palliative care. It's only after September 2019 that undergraduates onwards, they have sessions on attitudes, ethics, and communication skills, which is very, very important, because like I always quote to my patients, that the medical is in India, it's a very transactional relationship between a doctor and a patient. There is no relationship which is built with compassion and empathy. I am the doctor, you are the patient. I have read medicine, you have to listen to what I do. It's very paternalistic. And somehow patients also say doctor Bhagwan hai, like doctor is God. While in the West, the situation is very different. Patient is God. Both need not be, put on a pedestal. Both are human beings. Both are, one is suffering, one is there to alleviate the suffering. Point is, it's very vital for doctors to have a shared decision making and treat the patient as a person. Because of the era of super specialization, we have a doctor looking at the lungs, we have a doctor looking at the heart, we have a doctor looking at the brain. We need a doctor to look at the human being. What would he have wanted? What is his wishes? What are his fears? Or what are his anxieties? Just to sit and ask a patient, what do you want to do? It's not all about me. I'm not going to endure the dialysis. I'm not going to endure the surgery. It's important for doctors to share enough information, not in medical jargon, so patients can process and analyze and come to a conclusion that I don't want this and I want this. And be able to ask your doctors, what if I do this? Is it wrong? Or what if I don't do this? This is the point where you really need to sit and be able to communicate with your patients. In India, unfortunately, it's all money, especially private practice. The more you see, the more you earn. So the time spent with patients is also less. All the more reason that busy consultants therefore need a backup with palliative care consultants, so that difficult decisions or difficult patients, like quoted by medical doctors, like too many questions, or patients with difficult diagnosis, have enough time to discuss their fears, their worries, their anxieties, etc., and plan for their end of life. Because they know, for example, an advanced cancer patient or a dementia patient, you need to realize that they suffer this illness for a very prolonged period of time. It's not like cancer, where there's a lot of research done and there's a probable prediction that the 5-year survival rate is this much in stage 1, or the 5-year survival rate is this much in stage 2. So you can actually quote figures to patients if they have a particular kind of cancer. With non-cancer, it's very much unpredictable, like dementia, like chronic renal disease, like chronic lung disease. You can't say that, yes, I have diagnosed you at 60, you will die at 85. It's not going to happen because of the way the natural course of the illness is very unpredictable. Second thing, the non-malignant conditions are not perceived as life-limiting. So if I diagnose a patient to have dementia, he doesn't think, oh, how soon am I going to die? If you diagnose a patient to have lung cancer, he's already starting to think of how much time do I have to live. So it is very different, even patients are accepting palliative care when it's cancer, while non-cancer patients. So it's both ways, Geeta. And like you said, we really need to work to both so that we get the doctor fraternity as well as the community at large advocate and use technology to promote awareness. Tell patients their right to ask for palliative care. It is their right to be comfortable. And also educate doctors, family physicians, hospital consultants, hospital administration. Because for the hospital administration, not admitting a patient is loss of revenue. But goodwill is something that all hospitals need. If you agree with me, doctors and hospitals, the trust and faith is at all-time low in this country. So I have family friends calling me from across the globe saying, this doctor in this city in India has told my father to do 1, 2, 3. Should my father be doing 1, 2, 3, or is it unnecessary or over the tops? See, even for example, during the pandemic, unnecessary CTs were getting done. There was no need to do the CTs. There's no need to do the D-dimers and all in day week, the first week. So a lot of commercial interest has diluted compassion and empathy. I think we really need to approach both sides to make them meet in the center. Unless people start asking, doctors are not going to start offering palliative care. So it has to be awareness is my first, important point, and advocacy. We really need to get to as many people as possible. So I'm glad that people like you from the US who have loved ones in India can actually start spreading the word in India. And there are centers across the country. They might be in small numbers, but there are, for our population. It's not that there aren't palliative care centers across the country.
See, even in the US, from what I've read and heard, it started with advocacy and activism. There was resistance from the general medical community because, hospitals benefit from treating and, endlessly providing medical care. So I want to talk about how, from a patient's perspective, what does palliative care look like? So if someone signs up for palliative care, because you need it is a holistic approach, and that is you take care of the medical issues, you take care of the emotional issues, planning. There is planning. So someone diagnosed with dementia, for example, my dad, when I took him to the neurologist, once the tests were done, I was sitting with a social worker, and she talked to me. There was that empathy, I received from her, and she pointed me to resources and so forth. So that was missing here. So how does it work here with palliative care? You need a team to address many things.
So palliative care, that's the other beauty of it. It is not done by one person. It is a multidisciplinary team. And palliative care is need-based. It is not diagnosis-based or prognosis-based. Every family copes with a particular situation differently. So it's need-based. So there is a palliative care physician at the center. There are nurses. There are social workers, like you said you had in the US. And depending on the need of the patient, there is physiotherapists, counseling, if there's a lot of anxiety. Sometimes you have young people diagnosed with terminal cancers. It's devastating for the family. The parents need hand-holding. So it's for all ages. It is not just for the elderly. It is not just for people with terminal illnesses. It's at all stages. And it is a multidisciplinary team. The doctor is mainly needed for the first assessment and then timely periodic assessment to judge the needs of the family and the medical needs of the family. The counselor plays a huge role to prepare the patient for what is coming in future, to prepare the caregivers to how to handle, how to cope, how to self-care, how to take a break, not to be 20. It's not that if you're stuck to the patient 24/7, you love him or her the most. You need a me time. You need a time for your own exercise. Unless you are mentally, physically fit, you can't look after, you can't be a caregiver for somebody. And you and me, Geeta, have both been caregivers. We have hands-on experience. If you've not slept for 4 nights in a row, you are irritable, you are sleep deprived, you don't feel like talking nicely to people. So you need your breaks, you need your respites. And it's not always easy. Just because you are here doesn't mean you're the one who takes all the decisions. That also can be emotionally very challenging because that person is a parent for you too. So shared decision, other people, like I always tell families, argue with each other, fight. This is the time to do it because you're doing it in the best interest of your loved one. You can't corner one person and say he or she will take the decision. So palliative care is a multidisciplinary team. Yes, the US is way more advanced than we are. We are probably 15 to 20 years behind the US. But still, I think the doctors and colleagues of mine in the US say that they get referred fairly late. The earlier the integration, the better. And it doesn't mean that the curative options need to cease. So as the treatment is going on, if you introduce the palliative care physician, the patient also has a continuity of care. It's not that, okay, now there is no cure, so go to palliative and abandon the patient. The patient has seen his neurologist for 5 years, his pulmonologist for 8 years. So the transition has to be smooth from curative to palliative. And the earlier we introduce, there's so much evidence to say that the earlier introduction of palliative care not just makes the quality of life better, patients live longer, live happier, have less unfinished business, less unnecessary hospitalization, caregivers are looked after, and there is no burnout for the caregivers. So many plus points for palliative care, and it really doesn't require rocket science. It requires a group of people who are trained to manage symptoms, to identify difficult issues. And yes, we might not be able to solve everything, Geeta. Like, I can't make a dying person be alive, but at least I can share the burden. I can be there. One SMS to the person, the caregiver, or one message saying, how are you doing? Did you sleep? Have you eaten? How was the night? And that makes a difference, because I know how I felt when I got that message from my friend saying, did you sleep last night? How was dad? How is dad last? It makes a difference. I can't change the course of or the outcome, but I at least make the journey more bearable and be there for my patients. And even during the pandemic, I couldn't be physically there for patients, but the WhatsApp calls, the messages, the Zoom calls, to just see the patient and the family members was a lot of hand-holding for them. And this does kind of ease the suffering. I cannot replace the person. I cannot feel the experiences of loss that the caregiver feels, but at least he can share, he can, cry, be angry, and it is a part of the healing process. So to be there for your patient is important. And again, because of the various multidisciplinary team, like you said, patients open up easier to counselors or to social workers. They're still intimidated by doctors. Oh, it's a very silly question. Say they want to ask something about diapers. How can I ask the doctor this? It's such a stupid question. But when you have other levels of other paramedical skills, then they are in the safety net and we don't lose the patient, or the patient still gets help, whatever it might be. Suppose the patient wants to know, where can I get a South Indian meal from? Suppose the caregiver has come new to the city and he or she doesn't know. But that's important, because you really need to be fed and hydrated to look after somebody. So these are small things which can help, even if we cannot help the outcome of the patient.
Yes. I totally agree. I have another question about, you had mentioned that both you and I wanted to keep parents at home. Like my dad, he died at home, and just not take them to the ICU, as much as possible. But a lot of people dying in the ICU, and my cousin, she had cancer and she really suffered, and she passed away last year. And that is something that has stayed with me. And I had a conversation with her husband, actually. Why wasn't palliative care considered? Was it because it meant end of life? Was it? But what happened was, we have been talking about many barriers, the lack of awareness and education. But one of the barriers, what happened was infrastructure. It seemed like she had respiratory issues, and the level of oxygen input she needed would not have been possible at home. So she had to be kept at home in the ICU. So she died in the ICU, and that I always felt, I feel sad about it, because if she had been at home, maybe we could have held her hand and we could have been with her. So is there a lack of infrastructural facilities in India?
Again, Geeta, like I said, palliative care is need-based. So palliative care can start anywhere: home, outpatient clinic, casualty, which is emergency. We offer palliative care even in ICU. When we know that a patient is not doing well, that's when the patient is transitioned to palliative care, and we initiate palliative care. So these family caregivers are given some concession. They're allowed to spend more time. We do less invasive things, and we focus on the comfort. Now, when you talked about your cousin, it brings me to the point of advanced medical directives. Unfortunately, even if it is now available in India, very few people are aware that you can make a living will. People are quite happy to make a financial will and decide which estate goes to which son and which daughter, but they are not aware and therefore not open to making living wills. So if you see the website of Indian Association of Palliative Care, there is a section on the legalities and how you can make a living will. Currently in India, the logistical process of making a living will is extremely tedious. So there is another submission to the Supreme Court to make that easier. Having said that, if the treating doctor and the patient and the family have had detailed conversations, especially in a chronic illness, like I said, doctors treating a chronic incurable illness should be able to foresee and foretell, because he or she has seen 100 such cases of, say, dementia or 100 such cases of motor neuron disease. He knows the natural course of the illness. So it is the onus of the treating doctor to sit the family down and say, this is your diagnosis, this is what you expect year after year, and this is how it's going to end. Because he has a rapport with the patient and the family, having treated the family. And when the patient and the family are aware of how it's going to progress, and enough time is there for them to process and analyze, then the patient, when he still has the capacity to decide, signs the advanced care directive. Because once you lose your mental capacity, you obviously don't comprehend, you lose the function of processing and analyzing. So when I speak to patients with neurodegenerative conditions, way as early as I can, I tell them about unfinished business. I tell them to have bank nominees, put their flats under their children, donate, tie up all the loose ends, and actually sit and talk to the caregivers to make memories, to record their voices, to record their videos, because these things are not coming back, especially in a degenerative situation. They suddenly stop walking, they stop talking, they stop swallowing. These are small pleasures in life which you want to cherish. And this can be done only when the person is still doing it. And the other important discussion we have with the patient who is competent is to talk to him about goals of care. What do you want us to do in an emergency? Suppose you have breathless, or suppose your condition deteriorates and you are not able to tell us what to do. Tell me today what you want to do, given the fact that your underlying background illness is incurable. So tell me, and those are the things we document. We get the signature of the patient, the caregiver, and the family doctor, and we communicate it to the treating consultant. So in case, even when there's an emergency and say somebody is saying, no, how can we look after him at home? Let's go to the hospital. Then if there is a living will, then we do only comfort care. So like in the US, if you have a living will which says do not intubate or do not resuscitate, if you happen to do that, it becomes you can get sued for going against the living will. So this has to be made more popular, though the logistical way of making a living will is still complicated in India. Talking to the doctor, ask your doctor, can I make a living will and keep? I don't want to be, for example, there are people who have a catastrophic brain bleed, and 1 minute they are fine, the next minute they're not. Those patients actually will benefit by donating their good organs to others. But when you put them on the ventilator and prolong their poor quality, unmeaningful life, you actually lose a chance to save other lives. So it's very important for doctors treating patients with chronic life limiting, at least, to have the conversations early, talk to your patient and family when they have the capacity to decide, and also write or document a living will. And the format is available on the website of Indian Association of Palliative Care. I'm happy to forward it to you too.
Yeah, that's great. A lot of these things resonate with me because I went through the planning. Once my dad was diagnosed, there were many things to think about. So very important information. Yes. So one of the questions that I think Chitra is put in the chat also, is how would someone know to come to you? You know, in India, do you get enough referrals from primary care physicians? Or, I mean, I found out about you by accident because I knew to ask for palliative care. So how does that happen? And what are the different resources available to them?
Yeah. So
for
again,
palliative
if
care?
you look at the website of Indian Association of Palliative Care, each zone wise, there is availability of palliative care services, which has been catalogued very nicely, and there's a full detail of addresses.
Okay.
I would say that in the 5 years of being in palliative care, the first year I did nothing. Nobody knew me. I hardly had any patients. And like Dr. Rajgopal encouraged me, saying, Rajam, first they will ignore you, then they will fight with you, then they will laugh at you, and finally they will accept you. So I'm in the process where they are fighting and laughing at me now, because the hospital consultants are my biggest enemies. And it's a very surprising thing, Geeta, I would like to share. One of my hospital consultants called me to see his 85-year-old mother. And I was trying to write down goals of care after discussing with her and him. And he said, no, she's my mother. I will do everything. I said, does she want everything done? No, I will talk to my mother. I think I made a mistake by calling you doctor. And then he insisted that I shouldn't sign for my consulting. And I looked at him and said, anyway, doctor, I wouldn't be charging you because you're a doctor. I wouldn't charge doctor's mother according to the, it's not right. Nobody charges my folks in this country. That is a prevalence where doctors' parents and kith and kin are not charged.
That's
so I
an
wouldn't
Indian
charge.
thing.
Yes, very Indian thing. Correct. So, and unfortunately, he is now in the hospital for the past 65 days, unfortunately, in the ICU on a ventilator, and there is no way out. And it's odd when I say this. I really wish him well, and I really wish, I mean, it's something like you get what you give, So the biggest problem is hospital consultants. The problem is they feel, how can you give up? Second thing is, the richer you are, the worse medical treatment you get in this country, because you can afford to pay the bills. So what is the reason to pull the plug? Suffering is not considered as an outcome at all. Second thing, what people focus is on survival. How you live your life is not important. He's breathing, he's alive. There are some people who say, I'm happy if my father is alive. But this is not how your father wanted to live his life. So the problem is now the referrals have started, and it's usually word of mouth. There are some hospital consultants who have realized how integrating palliative care with their patient care has changed the outcome of their practice, because there is so much less discussions with the patient, because I do all the difficult discussions with the patient and the family. So they are only called in for their specialist intervention. So now there is a bunch of doctors who realize the worth, and therefore I am slightly busier, but it is patient to patient who says, please contact Rajam, she will help you. So now the referrals are coming, but advocacy in this country is much desired, and we really need to focus on how to make people more aware.
Yeah, I was doing some research and some stats came up that, while we have, because of the huge population, there is this huge need for palliative care. India comes near the bottom of the end of life care, ranked 67 out of 80 countries in 2015, with Kerala being an exception. And also, what was that called? The quality of death index. It was very poor, considered very poor. And I think you mentioned something. There is, giving up. It's considered that acceptance, that there is nothing more that can be done. And just what we need to do is keeping them ensure quality of life is interpreted as giving up. That is, yes. So that is really sad.
The problem with India is like what the COVID highlighted. There is no universal healthcare.
Yes.
Two, there is very poor infrastructure. COVID highlighted all this and really exposed how bad the infrastructure of healthcare is. The third thing is triaging and selecting patients into the ICU. There was, so that's where we come in big time. So that's what we did in COVID, and talked to relatives, 90-year-olds, 95-year-olds who got COVID with multiple organs. We talked to them about comfort care so that a 30-year-old or a 50-year-old could go into the ICU, because there are only that many ICU beds in the country and there were only that many ventilators. So yes, in India, less than 2% get palliative care. Out of the approximate 8.5 to 10 million who die every year, it's less than 2% who get palliative care. And the other horrifying statistic is 55 million Indians go below poverty line trying to keep their loved one alive in the last 2 weeks of life. So it's a staggering people who are literally on the roads because nobody explains to them about how comfort care is way better, not just to the patient, but to all of you. Your loved one wouldn't ever want you to be on the road and suffering by paying his bills. And unfortunately, we are not able to reach the urban. This is even urban India is struggling, and the rural India is something we've not even thought about. But Kerala, the difference in the Kerala model, it's a community-driven palliative care model. Yes. So it is every Gram Panchayat has an association and contact with community with the palliative care. So if they find somebody in their locality unwell or having a problem to access to getting to hospital, etc., they contact the palliative care doctors and they go across hills, rivers, bridges to meet. So I have actually, during my training with Dr. Raj Gopal, you can actually check out the Pallium India website. We actually train the caregivers to do wound dressings. They supply medicines, they supply Foley's catheter, they teach them how to change the Foley's catheter, how to do physiotherapy, because we go there only once a week or once a fortnight. So we empower caregivers to look after their loved ones, because Kerala also has a lot of young paraplegics and quadriplegics trying to get the coconuts out of the high trees. And there are many people who have fallen from that height and have broken their spines. So they rehabilitate the paraplegics by making them teach to making umbrellas or teaching them how to make chatai. So they rehabilitate the patients also, so that there is some income to the family. So Kerala model is very different. It is also there is a lot of political will, and also it is a 100% literate state. So the approach is very different. So it's a very different society. Yes, it is probably the best state in the country to die in. Having said that, now there are a lot of states in the country who also have the palliative care support, and there are some fabulous NGOs and medical colleges who are doing a wonderful job. But there is lots to do. There is lots to do in this country.
No, it's very impressive. What I've heard about Kerala, and they have this palliative care policy by the government. I think that's the first state to have that. So now I want to talk a little bit about pain management, because that is something that when you think about anything painful, if long drawn out, it's not necessarily death. When we talk about quality of life, we think about pain management. And again, my experience was, I reached out to the doctor when my father, I could see him suffering in the last 4 days in particular. And I could see this, he didn't even have the voice to scream. And I could see him feeling that pain. So I was thinking, can you give him morphine or something, to alleviate the pain, because we are not able to get rid of the infection. So I know, can you talk about that a little bit? Because there is the opioid administration it's very restricted, and what are the barriers and how can we change that? What is required?
Very important and very, very poignant for us to talk about pain. And Geeta, between you and me, very often culturally in India, we are all brought up saying endure pain. You cannot complain. Your threshold for pain is too low. How can you complain about pain? And that itself, it's not just the physical pain, even emotional pain, the spiritual pain. It's when we talk of pain, somehow we are only focused on physical pain, but a person can have different kinds of pain. And I think identification is important. Do you know that we are not taught about pain at all in medical school? We are not taught about the mechanisms and pharmacodynamics of opioids. So when we pass out from MBBS, opioid is a drug we never know how to write. So there's opioid phobia amongst physicians. Then amongst the community, there is, I will become an addict. And unfortunately, that's what the US has gone through. The US has gone through this whole thing of having opioid, so much of addiction, that now they are becoming wary of writing prescriptions of opioid and dishing it out, because I think they used to really dish it out like a packet of gems in the US. So, we were in that, we are actually the maximum producers of morphine. And the utilization in India is the least, because doctors are not trained. You need to have a license to prescribe morphine. And the other big thing is that there is a lot of opioid phobia even amongst the patients. So I have patients who I have to convince 5 times, 6 times, at least try this to relieve the pain. So it's both ways. Doctors are also not aware, patients also don't want. The other thing is that now in India, again, a lot of people are not aware of the revised Narcotics and Psychotropic Substances Act. It has been revised in 2014. The licensing, the procuring, and the stocking is not as complicated as it was before 2014. All you need is a registered medical institute approved by the Food and Drug Association. Then the hospital gets the license for procuring morphine, and you need a person trained to stock and record the medication, so that if you had, say, 10 strips of morphine, then you need to show that where the 8 strips have gone, whom the 8 strips have been given to. So that kind of methodology needs to be maintained, because we don't
Can
want...
it be done at home? Can it be done, administered while the patient is at home?
Yes. So what we do in palliative care is, when we give a prescription, we give a triplicate prescription. One is saved in the chemist shop, one is given to the patient back stamped, and one goes to the ministry so they know where this morphine has gone. Second thing, when we write a prescription, it can be only valued for 3 days after the prescription. On the 4th day, he tears the prescription and throws it into the bin. The chemist.
Okay.
Also, when we write the prescription, we put our license number. We also write total number of tablets to be dispensed. So when I talk to the family physician, I say this patient should have had 10 strips or 5 strips of morphine, total 5 into 10, 50 strips. Please, can you count how much morphine the patient has now left in his box?
Okay.
So those are the care we need to take, because we don't want morphine to go into wrong hands. Very often people have caretakers in the house. We don't want, when they are dispensing the medications, we don't want them to pop it. So we keep an idea of the tablets, etc. If the patient dies and they still have morphine, we tell them to flush it. This whole thing of sending it back to me in the transit, all that, we don't entertain that, and we don't encourage it, because morphine actually is a 30 rupee tablet in the country. One strip of 10 tablets is 30 rupees. And it is such a small amount compared to the relief it gives for patients and caregivers. So we again need to emphasize on morphine value. It's not that morphine means patient dies or patient has to die. My patients with respiratory failure and morphine live for 8 to 9 months and live so well that they can do small pleasures in life, like complete a sentence on the phone, walk to the toilet independently, because these things are a Herculean act for them. A person who is breathless 24/7, 365 days is relieved by the fact that he can wipe his back on his own. It's a big thing for him. And that can be achieved by opioids, but there is a lack of awareness amongst physicians as well as fear amongst patients and caregivers. Because what will if I become an addict?
Because I specifically asked for it. I asked for it, and there is a lack of awareness. So from what you're telling me, because you said the use is very low, so there is a lack of awareness that it is possible to get it, and it needs to be regulated, and you have specific procedures for administering it. So through palliative care, there are possibilities for getting pain relief.
And doctors trained in palliative care now have the license to prescribe it.
Yes.
But alternate medicine doctors are not allowed. So homeopaths and Ayurveda doctors are not allowed to prescribe. It's only allopaths trained in palliative care are allowed to prescribe.
Yeah. So the next question is from Chitra. Since Amicus Brain Innovations currently is focusing on dementia, are there specific palliative care practices for treating people with living with dementia and their
Yeah.
caregivers? Yeah.
So I think we have now started realizing that more and more Indians, when I trained for MBBS, we used to hear of dementia from the West. Now Indians have started living longer, and we are going to be a gray nation in 30 years. So the statistics of in an article I read is by 2050, we are going to have a 300% rise in 60-year-olds and a staggering 700% rise in 80-year-olds, where you and me, Geeta, in the next 30 years will be 80-year-olds. So we are going to be a gray nation. And it's scary because we do not have the infrastructure. Who's going to look after all of us? So it is important, therefore, to spread the awareness of palliative care so that we need it when we reach our 80s. So in dementia, so the percentage and incidence of dementia and other neurological degenerative conditions is going to increase in an aging population. So currently what we do is we have this in Mumbai. I'm a part of this Mumbai Palliative Care Network, where it is informal group where all those people offering palliative care across the cities, NGOs, independent doctors, hospitals are all, we have a group where we meet now, of course, virtually every 2 to 3 months, and we plan advocacy programs, awareness programs, or help each other out. I have a patient in Borivali, I have a patient here. So how can you arrange morphine? So all this is what we do. And the other thing which we do so basically we have this group where we kind of get palliative care to the patient and not the patient to palliative care, because a lot of times patients are not able to go to places. So they need home care. And one of the biggest advantages of palliative care is that we try and provide care in patients' homes. So what we do for dementia patients is, one, like I said before, talk to patients when they have the capacity and they have the capability of talking and deciding for themselves. Unfortunately, most of the times we reach late. So now there is a neurologist at Hinduja, Dr. Roop Gursahani, who is a very pro-palliative care physician. He has actually started courses on neuropalliative to educate neurologists about the need to integrate palliative care with neurology training. When do you start palliative care? What are the advantages? How it's important to be truthful, to prognosticate with patients. Then the other big chunk is to try neuropsychology. So there are psychologists who actually go to patients' homes and encourage the gray cells. So they have games, they have, especially people who can afford to do these things. So there is another website you could check. There's a lady called Tanvi Malya, this is of course Bombay. Yeah. Tanvi is the one who does all this so that, kind of keeps the person active mentally. Then we have counselors to talk to relatives, because it's extremely challenging for our caregivers to look after somebody who's changed so drastically. We also have caregiver Sathi now in Bombay and Delhi, which is run by another friend of mine called Bhavna, who looks after the caregiver burden for such chronic. And we want to start a support group for caregivers for this illness, so that they can exchange notes and be there for each other and try and help. And we also, as palliative care physicians, plan the goals of care. So about recognition of deterioration, about pros and cons of putting feeding tubes, about whether we need to admit these patients into ICU, rope in the family physician, explain to them the whole process of why this patient should not be going into hospital or should not be going into the ICU. This is what the patient wants. Or even if you go to the ward, what maximum ward care can be done to keep the patient comfortable, especially in dementia, because a change of scene can be very frightening for the patient. The familiarity helps. So these are the things we do to plan so that the end of life is a smooth transition, and it's not that the patient is made to suffer or prolong his life. So there's a lot needs to be done, but individual cases, there is a lot we do. Even during the COVID pandemic, we had Zoom meetings with children abroad. so that the caretakers, the GP here, parents alone here, kids could not come. We've had Zoom meetings. We've documented what the family wants because the father was not able to decide. Told the GP to record. So we've recorded the Zoom meeting, so it's medical legally safe, and it's not something that I just wanted to do it as my whim and fancy. So that everything is in place, so that because every doctor is worried about the court of law, But if you communicate well, if you document well, and if you are in the for example, in the good, if you've taken the family into confidence, that grieving family is not going to leave the patient and go to the court of law to file a lawsuit against you. So you need to be there for the patient. You need to talk to your patients from time to time. You need to understand that they might go back and forth. It's not easy living with the decision of I'm not going to do anything aggressive for my father. How can I not do this for my father? So I think these things are very, very important. I think communication is something which really has to be emphasized, because what we say, another thing is that palliative care is narrative medicine. Like the surgeons do their skilled surgeries, we communicate to the patient and family and see to it that we have a plan of action and goals of care, and plan all this when the sea is calm. That's when you learn swimming. You will never learn swimming in a storm, and you end up making all the wrong decisions in an emergency. So you really need to have the time to process and analyze all the information that you get and integrate palliative care as early as possible.
It's very encouraging, all the work that you guys are doing. And also I can see that palliative care fills this huge gap that exists in traditional medicine, where doctors get very busy and there's a diagnosis, and then you walk away and there is this disconnect. The patient is left with the diagnosis, what is to come. So I want to, because we are a technology company, I want to talk about more to the technology piece. But just one last question before that: affordability and coverage by insurance, for palliative care. Can you just talk about that a little bit?
So in India, the NGOs who do palliative care do it for free. Okay. So like Pallium India does home cares for free. The NGOs in Bombay, I know, Palcare, Romila Palliative Care, they don't charge a penny. For home visits, doctor, nurse and counselor goes, and depending on the need of the families, more visits from a particular profession go. So NGOs in the country do it for free. They are funded by various agencies or donations, etc. So Kerala is a completely free model. If you look at Karunashraya, it's a hospice for patients dying with advanced cancers. They also run completely free, and they are, basically run on donations, and they have various international donations that keep them going. But in order to encourage more and more doctors to enter palliative care, and for the private hospitals to also see to it that they have a good quality of death, we really need to treat palliative care as a specialty, which will also earn money. So we know the point is it has to be sustainable. You can't expect a 25-year-old who's finished his post-graduation to not be able to earn, because he has to run a family too. So it now, with private hospitals getting in palliative care, there are full-time palliative care physicians with whatever package that they offer other consultants. So the point is, like I said, home care is important. Now private hospitals are thinking of having a package for people who can afford, saying, okay, 5 visits in, say, 6 weeks is this much. Or if you want to take a package for 6 months or 8 months, we make it cheaper. Okay. So the point is, if you think of palliative care for a dementia patient vis-a-vis curative care, palliative care is not as expensive for the patient and the relatives. Plus, it's extremely fulfilling to have all your queries answered and all the time for you to have somebody as a support. While curative medicine, you will not be able to reach out to your urologist, your pulmonologist, or your neurologist but in palliative care, all of us have a hotline. So if I'm not available, you will have somebody else to respond to you. So I feel that palliative care is not expensive. In fact, it is cost effective not to go down to the ICU, the hospital bed, the unnecessary blood test, unnecessary imaging, which is not needed. You know this patient has deteriorated. You have to keep the patient comfortable. So it is important to realize it's not expensive. And the other thing is, we are now pushing cancer, those patients with cancer who have taken up palliative care to be reimbursed by insurance. Non-cancer palliative care is still not reimbursable. So for example, I as a private physician, when I go to somebody's house, when the person is actively dying and I charge a fee, that might not be reimbursed by insurance. So that's also the reason why sometimes families prefer admission. You get what I'm saying? You show a hospital admission, they get an insurance reimbursement. But even if they do that, it is still my onus to see to that even if the patient is in the ward, the patient should be kept comfortable. Comfort is important. Yes, place of death is also important, especially if it has been told by the patient that I want to die in my house. But this is still not covered by insurance, not in this country yet. We are working towards cancer patients getting their money back if they choose palliative care.
Yeah, I hope there is enough advocacy for that, and
Yes.
that it
Because
goes
it is
beyond
also a form of
cancer.
treatment. So like
Absolutely.
like I heard somewhere 20 years ago or 30 years ago, I mean, we cannot envisage any hospital without an emergency or an accident or a casualty department. So I hope that in the next 20 years, we don't see a single hospital without a palliative care department. I mean, that's where we should aim. Everywhere we need a palliative care department, because like I keep telling this, quoting this, death is inevitable. All of us will die, but we should avoid bad deaths. And that will happen only if we start talking about death. We are such a death denying society. We don't want to talk about death.
Yes. Well, before technology, one quick question that came up. You mentioned hospice, and I meant to ask this right at the onset. In the US, there is a distinction between palliative care and hospice. I mean, hospice is it's palliative in nature, but usually when you think about end of life, 6 months out, I mean, they could live longer, but you know that they're not going to live very long. Whereas palliative care is they could live for many years. So does that distinction exist in India? Just talk about the terminology, hospice and palliative.
To be honest with you, hospice is where you admit patients for comfort care. Okay. Now, like I said, there are a lot of hospices in India for cancer patients because the end is predictable. For example, if you have elderly, if the person is not getting up from the bed, if the person has multiple metastases, you know he's not going to live for 2 years. So the predictability of end death is much better in cancer than in non-cancer. There are hospices in this country for advanced cancer patients. There is one in Bombay called Shanti Avedna. There is one in Pune, which is run by the Cipla Foundation. So there are many places, and they also charge nothing. It's free for however affording. Karunashraya is free. If you ever happen to visit Karunashraya in Bangalore, you will not want to come out of that place. I have done a 10-day posting there. It's a beautiful place to actually take your last breath, but that is also completely free. Having said that, it's very difficult for non-cancer conditions to have hospices. Like you said, your dad would have been in a hospice in the US. So socially and culturally, we are different because we have family support. At least we did have. Now it's different because it's nuclear families, fewer children. Now there are many parents on their own. So now it's different. But even 20 years ago, my grandparents would have never thought they would live alone. Now you and me, our generation, have started thinking, yes, I will be alone. I mean, even if I have children, they are not going to break their career and come and look after me. So things are changing socially and culturally. But till now, we always had somebody looking after the elderly person in the house. So therefore, the need for hospice was also not there. Second thing, Indians living till 80 and 90 is also a phenomenon of the last 2 decades. Third thing is real estate. Big cities in this country cannot have a hospice in the middle of the city. There's no room. So you have to go far, far beyond where relatives might not even be able to go. So in Bombay, there is one in Bhayandar, there is one in, beyond Karjat, which is very difficult, which is a 3-hour drive from where you live. So,
but again, I think you're talking about hospice in terms of in India, the concept is it is a location outside of home. Whereas in the US,
yes,
possibly other countries, you will have hospice nurses coming home, and the whole setup is at home. It could
so
be
that you can do with a palliative care team who come and look after your needs. There's a nurse, there is a social worker, there is all this that's happening that can be done at home, and the NGOs who do it for free. But this hospice care, for example, there are people with no children in the country and they have to be looked after. So now there are things coming up like assisted living. So if you look at RG Care, they have residential homes to look after such people. In Bangalore, I've seen that Sukhino. If you look up Sukhino, they have people who have dementia, Parkinson's, etc., who don't have children, or children are away. They have these places where they can look after, but they are not cheap. These places are expensive, so they are only for the affording. So that's also another category distinction where you have to be able to pay those. They can be quite expensive. So, and another thing is, I think in a dementia patient, the predictability of death could be 2 years to 2 months.
Yeah.
So, one bed is occupied for that person.
Yes. Just a quick pause here to announce that to everyone who is on the call, that we are going to be going beyond an hour. We are over the hour, but we are learning so much. We have definitely a few more questions, and we want to give you the opportunity to ask questions if it's okay with Rajam.
Absolutely.
Right. So thank you for that. So we are a technology company, so we're eager to know how technology can help palliative care in India. So as a doctor and as a palliative care physician, what kind of technology do you use currently, and what do you wish were available to, whether it is to spread awareness, for research, anything else, for treatment, anything else?
So I think the research in palliative care in India is absolutely minimal to non-existent. We really need to use technology to improve research. For example, I think even palliative care outcomes are not assessed routinely or audited routinely. Now, it's a very strange branch, because the one whom you're offering the maximum care to is not going to be alive to tell you how he felt in the process of the transition. So I think it becomes more important to focus on the outcome from caregivers. And since you all do focus on the caregiver aspect, I really think we need to use technology to focus on research. There are many websites in the West who have palliative care outcome scales for the caregivers and for the patients during their journey. So I think research is very important about how important integrating palliative care was for them as a family and for the patient. So we really need technology in research, definitely for awareness amongst medical personnel, awareness amongst patients, hospitals, and the community at large. Then when it comes to technology, I think we need apps developed so that doctors, family physicians have the treatment of symptoms as a ready reckoner on their phone. So for example, he's gone to a patient's house with, say, a lung problem, and the patient is breathless, and they have given all possible things, oxygen, they've given the nebulization, they've given steroids, and the patient is still breathless. So if he has an app where he can actually say, what do I do for this refractory breathlessness? And everything comes out, say, positioning the patient, massaging the patient, blow a fan on the face of the patient, at least the sensation of breathlessness becomes less. Talk to them about morphine, how to start the morphine, what other side effects can you expect from morphine, so that the GP is also empowered with enough information and can prescribe a medication without, at least then say, or contact a palliative care physician. Then he knows what next to do. So, I think people are using smartphones for so many things. We can use this to have a ready reckoner of how to treat. You have a patient who's vomiting incessantly. What do you do to stop the vomiting? Imagine the situation in the house where it's middle of the night and the human being is throwing up persistently. It's very scary. And especially when you know there is no cure for this and the patient has expressed interest of not going to the hospital, you still need to keep him comfortable. So I think this kind of an app. The other way we can use technology is to reach out to the rural India. Because in India, if you see the statistics of people using smartphones, is a staggering number. I think we are the largest place in the country where everybody has a phone, including the person who sells vegetables and fruits. So if we can use this to connect to people in the rural India, we can then have apps to, for example, them to reach out to us saying, what do we do now? What should be done? So telemedicine developed to reach out to the rural, so that even diagnosing things like epilepsy or malnutrition for children, it's not just palliative care. I think in general, medical health. And, so for example, you have a dementia patient who's violent, and they are treated very wrongly in the rural, while he just needs one particular medication, which will calm him down. So, and we have so many doctors that we don't need to stress out one doctor to be on call for this kind of things. It can be on rota basis, or it can be a couple of hours a day, but at least they know they will get genuine help. Because I think we really need to reach out to our rural population, and they get the worst kind of medical attention. So some way where, even using the advantage of, say, the US timings to India, or, something like that, to see to that we can help people who are not accessible, they were 30 kilometers, 40 kilometers from the nearest district hospitals, how we can get them help, even in palliative care. So, these are the things I feel: awareness, yes, and how to reach out to people far and remote.
Yeah, a lot of things, many things you said, the app, with all these ready answers, that is kind of thing that Amicus Brain Innovations has been working with specifically for dementia caregivers. What do I do? We have an application called Kiko, which says, what do I do when my dad gets aggressive, or there is some other situation that happens, he's not allowing me to change him, or things like that. So I think there are many possibilities with technology.
Even simple things, Geeta. For example, my mom just broke her arm, and even the concept of say, okay, and she gets up 3 times in the night, the use of a diaper, it doesn't occur to you when you're in the thing, but when somebody suggests, you say, yes, why can't I do that? It's easier for me, it's easier for her, it's easier for everybody. But it doesn't occur to you when you're in the situation, when you're removed from the situation. So it's just that, and it's a stupid question, but it does solve a lot of your issues.
Absolutely. When they fall, how do you pick them up? I have Googled it. I have looked for it on YouTube. So I'm now going to open it up for questions. I think I think Shri, do you want to take over? And
yes. So I would like to first actually thank Dr. Rajam. Thank you so much for an extremely insightful talk on optimizing the quality of life and mitigating suffering among people with serious and complex illnesses like dementia. The quality of life for caregivers improves as well. And
thank you.
So thank you, Geeta. So as we heard, the getting trusted high quality information immediately when and where you need is a time consuming task. So we worry about where the answers come from, what we read on the internet, or given all the misinformation. And we are stressed about balancing work and good caregiving. So Amicus Brain is here for the caregivers of the world. Our AI advisor apps provide knowledge, advice, resources, and a safe and private community that there is always one place available to you 24/7 where you can engage privately, safely, and securely. So please check out our website, amicusbrain.com, where you can click on request a demo of our solutions. Chitra has added that in our chat as well. The link is available there. And follow us on Instagram as well to be informed of our upcoming events as we engage, empower, and support caregivers everywhere. So now, if Let's take some questions if there are from our participants. You can either unmute yourself and ask the question or type it in the chat as well. Either way.
I have one, Rajam. Thank you.
Yes.
Rich information, the much needed one. I wish I had heard your talk a few years ago when my mother was diagnosed with Parkinson's. So I think caregiving life is full of regrets. You keep rethinking, second guessing what you could have done better. So, I hope others who are just, hopefully they'll take a lot of benefit and comfort from your presentation. One thing I wanted to ask, so something about advance directive, in the US, we have several organizations have made this available on the web. So we could have the patient express three things: who can make medical decisions on their behalf, and what kind of medical decisions they are comfortable about. Do not DNR, you mentioned, do not resuscitate, and so on. What's the equivalent in India? I'm very curious. Here, every state differs. So therefore, any tool I have seen has to be customized for New York versus Connecticut and so on. Can you talk about whether such a facility is available already, or how does one go about in India?
So in March 2018, March 9th, 2018 to be precise, a judgment was passed by the Supreme Court of India that people have a right to die with dignity. And they also said that withholding and withdrawing treatment is medically, ethically, and legally okay if you know there is no good outcome and it is not in the best interest of the patient. So Supreme Court has passed the judgment. It has to yet become a law. But what they also did in the subclause was that in the event where this patient has a poor outcome, where this patient has a chronic illness which is incurable, you can sign an advanced will, and they have a format of the living will in the Indian Association of Palliative Care website. Problem is, they have said they made the procedure very complex. You have to write this, go to the judicial court, get the person to sign. Unfortunately, the legal system is completely unaware of it, which is why I said that the procedure is very complex. However, if the treating consultant has communicated to the patient and the family, there is this format that you can follow. He fills it all up, has a witness to sign, the family physician to sign. Then in the event of the emergency, that is what is going to be followed. And that also talks about proxy of health. Like, for example, you have an attorney, you have a power of attorney for wealth, you have a power of attorney for health. So that if not me, it is my son, my daughter, etc., who is going, that also is there for them to sign. And it's not that once you have written the advance directive, you cannot change your mind. Like any other will, you are allowed to change your mind. So for example, you have written that I don't want to go to hospital, but you end up breaking a bone. You will be taken. So, you can say no. If it's a reversible situation, you should be able to give the choice of changing your mind. But if it's an irreversible, so all those clauses are there. I don't want a Rives tube. I don't want to be dialyzed, not to be put on an invasive ventilator. If my heart stops, do not resuscitate. All those clauses you can fill. But it is not logistically very easy to do that in the country yet. So therefore, I think in a country like India, if we promote palliative care and if we have more and more conversations and difficult dialogues with our patients, and we discuss death more freely than we do now, these things will automatically come. Like, for example, Geeta's mom has made it very clear she doesn't want XYZ. My mom also tells me very clearly, if it is irreversible, do not try to do anything heroic. Just let me be and let me be comfortable. So it's very obvious. For example, when my dad died with the stroke, 14 days later, my mom went into ICU on his 14th day after dying. She was actually developing a fever during those rituals, etc. But we didn't realize. We thought she was behaving oddly because of grief, mourning, his loss, etc. And then suddenly, the night before my sister was supposed to return to Melbourne, her oxygen levels started falling. I said, this is not right. She's an asthmatic. So I thought, okay, some cough here and there is acceptable. Then when we took her to ICU, it was a full-blown pneumonia. Mom on recovering said, why did you take me to ICU? You didn't take dad to ICU, but you took me to ICU. What was the logic? So I told her, Appa's stroke was irreversible. Pneumonia in 21st century in an urban city is reversible. So I at least have to give you that much chance to make it reversible. So therefore, there is also that window that you time test and do aggressive treatment. Okay, let us try for 2 days, but don't keep a patient on ventilator for a month and then say, now let's withdraw. So there's a time tested trial, which is acceptable because you're hoping that the person recovers. If he doesn't, you need to have a backup plan. So I told Amma this exactly, because it was a reversible situation, I took you to ICU. And here you are 6 years on. So, you have to be able to decide. Reversible, if it's irreversible, there is really no point prolonging an unmeaningful life. It is equal to torture.
I think my takeaway from this is we have to increase the awareness, along the theme you've always said.
Totally.
I also found that there is a superstition associated with it, which we have to help dispel. As though by articulating how I wish to die and so on brings bad luck. I found it in several conversations. And
so I
we
think
have to make
culturally it is always shub shub bolo. Arey, don't talk about death. Don't talk about death. Yes. But if you actually speak to a patient, the patient is already thinking about death. And what the person is not scared of is, he's not scared of death. He's scared of the process of dying. Will I be alone? Will I be in pain? Will I be choking? Will I be, this is what, and they want to talk about it. We hush it under the carpet. They want that conversation. It is.
You have an amazing way of describing. I loved how you distill and simplify things. It's
but
not
isn't it true? Very often we have relatives saying, don't tell my father he has cancer. Don't tell him that. And when you sit with the parent and you ask him, okay, how can I help you? He says, doctor, very often they say, do I have that cancer? And they're not idiots, right? They're going for radiation, they're going for chemo, they're big boards of the cancer hospital. How can you betray your own? Imagine you are going to be in that position later. Imagine your children lying to you about your illness. It is your right, your body. It has to be your decision. So that's the first pillar of medical ethics, isn't it? Autonomy. You really need to tell. And that's very often in the country, the patient is outside the room. We are disclosing diagnosis to the relatives. And it's not fair.
Yeah, with the dementia particularly, I found this happened, and I'm sure it's not an isolated thing. The handwriting, the muscular movements change, and therefore any legal documents, any wishes to be recorded formally, doing that much later in the disease, as disease progresses, becomes just so much harder. So
yes.
Looks like we have to engage right at the time of diagnosis the palliative care team, who will raise our awareness to here are the must-do steps, and when the patient is,
has the capacity,
cognitive capacity and their control of their muscles and all of those things will be simplified. Thank you.
Yeah, thank you.
So any other questions? If not, I would like anything else you would like to. Yeah, there is a question. I think.
Good evening. My name is Hari, and I am actually in Dubai.
Okay.
Hi, Geeta. How are you?
Hi, Hari. He's my neighbor.
Okay. I've been hearing since the beginning, and I found it quite informative. I had just one query on this particular presentation as to whether euthanasia is legal in India, or, what exactly is the opinion about euthanasia in India?
So thank you for raising that topic. I didn't want to mention that word, but euthanasia is not legal in India. And backing up this explanation, in a country where we have paucity of palliative care services offered to patients, euthanasia seems a bit illogical. So for example, just to explain it a little different, why do you want to end your life? Because you're suffering. You are suffering pain, you're suffering financial distress, you're suffering multiple things. If you see the number of suicides in this country, 1 in 5 suicides is health related. Either he cannot bear the pain, or he cannot get access to treatment, or he cannot afford the treatment, or is depressed with the treatment, or whatever. So what I'm trying to focus is, if you had robust palliative care services, if you looked after health-related suffering of your patients and family members well, there is no need to end life. So suppose you actually looked after somebody's pain, then the person doesn't want to end his life. So if you can talk about euthanasia if you already have given appropriate, robust palliative care. In a country where that doesn't exist, euthanasia shouldn't be talked about. And I think I will go one step further and say we don't want to give them the, that twisting of the rule to take the advantage of killing any human being because euthanasia is allowed. Because documentation, communication is very strict and rigorous in countries where euthanasia is allowed. So I think in a country like India, where palliative care doesn't exist as it should be, we should focus on spreading awareness of palliative care. Once you address health-related sufferings, even if you cannot change the outcome, you really are a strong pillar of support for the patient and the family, and it makes a difference to reduce suffering and therefore alleviates the need to end life.
Thank you so
Hari,
much.
I hope. Thanks.
Yeah, thank you, Hari. Hari's mom was in bed for many years, and I've known him from my childhood. So I can see, so the palliative care is a topic of interest. I can understand where that.
See, we are all going to be caregivers. Either we are going to be cared or we are going to be caring. So at all our lives, we are going to spend through that. So I think it's very important and very necessary to talk about this, because all of us have gone through this or will go through this.
Yes. Any other questions from anyone before we close? Anything else you would like to add to the discussion today, Rajam?
Only thing I want to say is huge thanks for this opportunity. I really hope we can spread the awareness of the need for palliative care in this country. And I hope we can get to train both doctors as well as community to start asking for palliative care. There has to be a demand supply. Unless people ask, doctors won't realize that they need to specialize and polish their skills. And I think my whole thing is, for my fraternity especially, is that we really need to get the care back, the compassion and the empathy in our practice, because we are going to face exactly what our patients are facing today, maybe in the future. So we really need to empathize with what people are going through now. And I really hope we can take this to the next level of spreading awareness, because this is something I'm very, very passionate about. I think there was a question about how to connect or something.
Yeah, there is Amina Mehta.
It's not a complete sentence. Yeah.
Actually, I wanted to ask, how can we contact the palliative care here in Mumbai?
So it depends which area you are in, ma'am. You can take my number. I can direct you depending on your need, etc. Where do you stay? You can contact me. I can send you my email address right here on this chat.
I know Geeta. I will contact Geeta.
Yeah.
Yeah, I'm also putting my email address here, so you can send me an email.
I will share your email address with Meena.
Okay, thank you.
You want to mute her? Shri, can you mute her? Yeah. So thank you so much, Rajam. This was such a wealth of information about a topic that is, not much is known, and we hope we can all work together, in achieving your vision for palliative care and spreading awareness. And I think we are all going to benefit from that. It's a much needed thing in India.
Absolutely. Yeah. Thank you for this opportunity, and it's lovely meeting all you ladies.
Thank you. And you have a wonderful evening.
Yes.